So you get your first case. You get a call from a rep or myself. And at this first case, the first thing that you need to know is you want to make sure that you identify different parameters of the case so you're well prepared. First of all is location. Then after the location, you're going to be able to set up like when you need to bring it there as far as SPD, as well as equipment needed, surgeon preferences, and those things. I think it's important, that location. And then the second thing is obviously you're working through time. Then you start to look into what is needed. Fourth thing is going to be equipment. And you start to look at those four things specifically, and at that point you're able to adjust specifically what to bring. Once you identify that you have a case, we want to make sure that we have the hospital or location in mind. Once you get that, we're going to call the hospital and get the current setup on the time, what level they're going to be doing, as well as the fact that what instruments are needed. Once we ascertain exactly what kind of case it's going to be, we want to make sure that we contact the rep or the physician if you have any questions in regarding what they need as far as instrumentation, disposables, and what are the parameters of when we need to get the equipment to the facility. Once you identified what kind of case it's going to be, if it's going to be an interlaminar case, a transforaminal case, or a cervical case, then we can actually adjust to looking at the instrumentation from top to bottom and assure that we have everything that's needed for the case, as well as disposables, and usually 2 or 3 of each disposable just in case if one was dropped or one extra was needed during the case. Once you identify the case, we're going to look at instruments. It's important to understand that when we have specific instruments, you're going to have your large endoscopic tray. Within that tray, we're going to make sure that we have the proper scope for that tray. If it's interlaminar or transforaminal, that's the 130 versus 181 centimeters in length. Within the scopes in these trays, you're going to have other instruments that are universal or specific to the length of the endoscope that you have. You'll also have drill bits in there, you'll have cannulas, dilators, everything that's needed. It's important that you reference and go through each of the 3 levels that's in that tray so that you yourself have a good understanding where in the tray it is, in which you're talking to a surgical scrub tech that you can actually visually see it, but also understand where they're going to see it, right hand, left hand, top, bottom, corner, middle, so they can find it accurately even if they've never done a case. I think it's also important to understand that we look at the consoles that are this. We have an RF generator specific for spine that's different than the sports arthroscopy generator. And also we have a spine drill NSK system that's going to be accompanied on some of these cases as well. It's important to make sure you have those 2 things with the associated foot pedals. Sometimes if we don't have a tower specifically in the account or we're using another company's video, we want to make sure that we have extra energy cords basically, or electrical cords specifically, that will be into the device, into the wall, because sometimes it's not within their current tower. When setting up for a case, you want to make sure that you also have disposables. Disposables will make or break your case. This is where they're going to use a RF probe, your drill bits. As you look here, you make sure you have RF probes. You have 28 centimeters for interlaminar approach. You also have 35 centimeters for transforaminal approach, and the length is very important, specifically on like what they need to hold. In a pinch, sometimes the 28 centimeters will work in the transforaminal longer cases. They'll hub out in about 2 inches less, 1.5 inches. Once you have these probes, typically you use 1 or 2 a case, so I usually bring 3 total for one case, just in case one drops. You never know, one breaks. They're very, it's something that the counts do not have. With that being said, also we look at the drills, these burrs. We have some specific for Arthrex that will work in arthroscopy that are available to you. The NSK ones that are separate, that also have a console that's completely separate, so you need to look and verify what drill they're going to use. But typically, again, you're going to bring 2 or 3 of these to each case, just because if one was to drop, we want to make sure we have another one, because again, all of these accounts do not have this setup. I think it's also the spinal access kits are specifically for transforaminal surgeries. Again, it's a longer spinal needle, 18 gauge, because the 18 gauge needle will allow you to have a nitinol wire pass through that. Again, the accounts do not have these longer spinal needle kits. Typically, they're about 4 or 5 inches. These are sequentially about 10 to 11 centimeters. Also, the Y-inflow tubing is for gravity. Our system, we predominantly use gravity tubing. These have 2 exterior spikes, as well as another lure lock that will go on to the stopcock for these cases. That's important. We bring 2 or 3 of these. So typically, all in all the disposables, you want to make sure that you have 2 or 3 of each. You want to check these prior to sending out to case as an extra tub. Also, when you get to the case the first time, you want to make sure that you have all the disposables needed, just in case if you need to call in another one or have someone try to get one for you. Once you collate everything together, you have your instrument trays, you have your disposables, you have a possible tower that you need to bring into certain facilities. We need to make sure that we communicate with our courier or make arrangements with our team to bring the instruments and the tower and disposables to a specific account. You need to do that by requesting that through your team lead or coming to your local manager, myself, in which we can put that all together for you. When going to these accounts, sometimes with the energy consoles as well as the drill consoles, you need to go to Biomed. And with that being said, we do that sometimes a couple days before due to getting an appointment or having to plug it in and signing off on it before your case. All right, so the day of surgery, you want to make sure if it's a 7:30 case, I try to get there at 6:45 due to the fact that we have to set up a lot more than your standard arthroscopy case or fracture case in which the room is set up by you get there, because it's important for us for spine endoscopy. The first thing is to make sure that we identify which room is going to be in the setup, because we want to make sure that within our spine endoscopy cases that it's a right or a left side pathology. With that being said, if it's a right side pathology, the surgeon and the scrub tech are going to be on the right side, and on the left side of the patient is going to be the C-arm video monitor, our video tower, and sometimes the C-arm depending on room configuration. Now that we understand what time to be there at the case at 6:45 or 7:30 case, and also the setup if it's a right side pathology or a left side pathology, we want to make sure also that we get to the rep storage area for our RF generator console, our foot pedals, as well as our drill console, and we also want to make sure that we have all of our disposables that we'll be taking to the room. Once we've got all of our disposables as well as our consoles and we're in the room and we have the right side set up to what we need to do, Scrub Tech will be opening up our large endoscopic video tray, a mid-video tray that will have camera heads as well as light cords and sometimes a drill motor cord. And then potentially we might have an extra scope tray or a Tremonto arm tray with that. As we do that, we want to make sure that we are setting it up with them, and as an efficient process, we're going to do that starting with a large endoscopic tray. Unlike any other spine cases, the drapes are really important for our spine endoscopy to capture the irrigant that's coming out of the scope. I think that it's a lap chole drape with pouches, a crani drape with pouches, sometimes a shoulder drape with pouches with work. But also we want to make sure that we identify the drape prior to the case starting, and if needed, we talk to the surgical circulator to find it. Also, we make sure that you have 2 IO-band to help secure the area in order to the irrigation or irrigant to be captured and sent to the Neptune. After draping the patient and having the right drape with all the different aspects of IO-band, we want to also make sure that as we set up the surgical field, that we set up all of the proper light cords, video camera cords, tubing for suction, as well as the inflow, RF cables, anything associated with all of the different surgical devices on one area, one by one, and then off the field, so we have enough slack in which we're going to be running 6 feet off the field. And I think it's important that we start layering them from the top of the patient down, or on top of the Mayo stand down, so you don't have any cords that are commingled together, in which could inhibit your ability to do a case efficiently. Once you're supporting the case, we want to make sure that you keep sterility a number one focus in these cases, due to all of the different cords and devices coming off the field. It's important that we stay 3 feet apart from the field itself and some of the cords, due to the heightened sense of sterility. I think also it's also important to make sure that you have the circulator plugging in the camera source, plugging in the RF probe, plugging in the drill motor or motor piece that's needed. I think that will go into our sterility field on that aspect. The other thing too is the safety aspect. You want to make sure in these spine endoscopy cases, they will be taking some shots with x-ray, so make sure you have lead on. Again, this is something that is really important for your own safety, and also within the case support. With the safety aspect of that, I think also as we start to go through, anytime that we have disposables, we want to make sure that we are handing them to the OR circulator so they can open up, read off the expiration dates, indicated use or IFUs if they need to look towards those for any cleared indications. That way we can clearly support the case from 3 feet away, and also the fact that we keep a confidentiality of our support there, and we're not potentially de-sterilizing certain products. A number one rule in these spine endoscopy cases is to support the nurse in the case, because they're the ones who's going to make or break your case as far as efficiency and also setup and also all the other things that they need. I think it's important to preemptively before the case to talk about sequential landmarks in the case of, hey, we'll have a tower in here, it's going to be the opposite side, we're going to have all of the surgical flow will be this way if you need any help with this, but these are our parameters of the RF generator at an 80-50, 80 at cut, 50% at coag, and also here's the higher end of our drill box at 80,000 RPMs or 9,000 RPMs depending on what burr you use. And also the ability with our video system. I think it's important that we support the nurse, because with doing so, she'll feel confident, and also the fact that it'll create a surgical flow. In the spine endoscopy case, we want to make sure we also support the surgeon specifically, not necessarily as technically that we'll get into later on in another video module, but it's important that we support the surgeon in knowing how to connect the scope, how to connect the light cords, how to connect the drill, and also to make adjustments in the case. I think it's important that we know the settings within the case, from recording options from 5 minutes typically with arthroscopy now to an hour. These are longer cases sometimes that they need the full hour. Understanding how we can support the surgeon on downloading the video that's been captured. This is something typically that's not done all the time, but it's something understanding what you need to do with a thumb drive on these cases. Also supporting the surgeon when he has questions when it comes into instrumentation, not necessarily a surgical technique, but understanding like what sizes you have there. If it's a small Kerrison that's 2.5 to 3.5, or we have certain scissors as a straight or angled, really custom, like get yourself acquainted with the graspers and pituitaries and the nerve hooks and the bone curettes and the different aspects of what they're doing. You don't need to know everything, but basically the small subtle adjustments of just saying a small and large grasper. Understanding also when it comes into clearing the field, if it's dealing with certain irrigation, that every 30 minutes or so a 3-liter bag is going to go empty and you're going to get stagnant water if you can't really, the irrigant, you can't really see the picture. I think it's important to kind of really help support the surgeon in that aspect, and we'll get into the technical module at another point. Congratulations, you finished your first case. It's important that we tear down and remove everything that we put on the tower and also the instruments that are in the field. The first thing we really want to talk to is the console. The RF generator box and also the drill console is not something that's on your typical arthroscopy tower. So we need to make sure that we take that off the field with associated cables. And sometimes with the foot pedals, but we need to take cavity wipes and gloves specifically and wipe everything down, because the sterility aspect of that is very, very important. I think that's where we're going to be taking and putting back into the tubs in the rep storage area. That's something that we want to make sure that we're carefully identifying, wiping down everything. Once we get through the consoles, we want to make sure that we go to the instruments. The instruments in the back table, after they've been pulled off the field and they're already done closing up, it's important that we go through every instrument and go every tray, identify what's missing, either write it down or look on the field or look on the floor. But it's important that we have all the instruments in these trays when it goes back into SPD. With that being said, also at the end of we're going to have our tower. Our tower doesn't sit in these spine rooms or even these orthopedic rooms. Usually it's on a different floor or out in the hallway. We want to make sure that we close it up. And at that same time with the tower, the surgeon might have a thumb drive, or you might have a thumb drive that's associated with the tower, in which you need to export the data to it so the surgeon can access it for patients debriefing as well as for their own technical work. Also, very, very important with paperwork, we want to make sure that we are writing down our ES-S1000 code for an instrument rental or fee, unless the facility owns the equipment. Outside of that, we're going to have our disposables that we need to make sure that we are writing down with the product number as well as the lot code number with that, and then the associated price for that specific account. Those are the details, and after that, through Red Spot, you can put in the invoice, send it off to specific people that can send you the PO, and at that point, you're successfully completed your case.